Welcome to the Canadian Breast Cancer Network's next questions and experts session, which is with Genetic Counsellor Rachel Mador-House. I'm Jen Gordon. I'm the Director of Operations. Thrilled to be joining you today, and just wanted to go over a couple housekeeping items before we get started and before I introduce our host for the session. So we will be recording the session today. If you do want to watch the recording, it's usually up on our website, cbcn.ca, within a couple of days of the live session. I will put the link in the chat as well. And you will also see that all of our other questions and expert sessions, as well as our webinars, are on that same page. So please take some time to go through those. I would like to extend our sincere appreciation to our sponsors for today. So our gold sponsor, Viatris, our silver sponsors, Novartis and Merck, and our bronze sponsors, Pfizer Oncology and Invitae. So in terms of the format for today's session, it really is dedicated to taking questions that were submitted in advance by participants, as well as those of you who are joining us live. So you'll be able to submit your questions throughout the session by clicking on the Q&A tab that should be probably at the top, bottom, or somewhere along the side of your screen, and submitting your questions that way. If you're not able to find the Q&A button, please feel free to submit them through the chat, and we will try our very best to get through as many of these questions as possible today. And now I would like to turn it over to the host for our session, Kathy Amandalea. Welcome, and Kathy is the chair of the board of the Canadian Breast Cancer Network. Over to you, Kathy.
Thank you, Jen. Welcome, everybody. Thank you for joining us again. I'm pleased to welcome myself, and on behalf of CBCN, welcome back, Rachel, who joined us last month for a webinar where she presented an excellent overview of understanding the role of genetics and genetic testings as it relates to breast cancer. If you did not have a chance to see her presentation, we would highly recommend that you take a look at the recorded version that's available on the CBCN website. Jen will put the link in the chat, and you can help yourself to watching it. Rachel is a board-certified genetic counselor with a Master's of Science in Genetic Counseling and a Master's of Science in Molecular Genetics. Rachel was the genetic counselor and clinic coordinator for the Maritime Newborn Screening Program, and also worked at the largest hematology oncology clinic in the Western United States. She is currently the clinical science liaison with Invitae. Rachel, wonderful to have you back with us today, and I'm sure you'll be able to answer the many questions that may have been not answered at the last presentation. Over to you.
Thank you so much for that introduction. I really appreciate that, Kathy. So yeah, thanks for having me again. My name, again, is Rachel. I'm a genetic counselor, so I'm a clinical expert in genetics, and I'm also a genomic scientist. So I'm a full-blown nerd, genetics nerd over here. And I would be delighted to answer any and all questions people might have about the link between our genes and developing cancer, as well as how that could impact our family members today. So thanks for having me back again. It's really nice to be here.
Great. So while we wait for participants to submit their questions, online, we'll get started with a couple of questions that were submitted in advance. So I'll start with the first question. And the writer asks, what is involved in genetic testing? Is it a blood test, tissue sample, saliva sample? And do different methods of collection give different results? So example, they're asking blood versus saliva. What are the differences? What are the results? Good questions. Overview, I guess.
Yeah, that's a great question. And Kathy, are you able to see this slide with someone sticking a little Q-tip looking thing in their mouth?
We are.
Yeah. So when you go for a genetic test, you're going to be asked to give either a blood or a saliva sample. There are certain rare kinds of cancers where actually a little bit of your skin is going to be taken off as part of the genetic testing. And that's just because that's going to be the best way to get a reliable answer. Those are usually for people that have cancers, what we call liquid cancers. So cancers in the blood or the bone marrow. And that's because when we do a saliva test or a blood test, we won't get very reliable answers if somebody has those types of cancers. That's why we take a tiny bit of the skin. But for the most part, what we're doing is we're taking a small amount of saliva or a blood sample. Now, the question, is there a difference between the accuracy of those two types, so saliva or a spit test versus a blood test? And the answer is no. Luckily, our technology has improved over the past few years. It used to be that a saliva test wasn't going to be as good at getting you a result, but over the past 5 to 10 years, the technology has advanced where, yeah, spitting in a tube is just as good as giving a blood sample. And there are certain people who might not be able to provide a saliva sample. We know that some of the medications people take can sometimes lead to some dry mouth, and it might be really hard to get enough saliva into a tube to do a genetic test. So a blood sample might be best for someone like that. Whereas there might be people who, especially for children, for example, that have cancer and might need a genetic test, a blood, they're being poked and prodded quite a bit, and maybe a blood test is not going to be the best experience for them. So spitting in a tube can make that a little easier. We also have ways, like you see in this slide, where we can use, it sort of looks like a little Q-tip to sort of run that along the gums on either side of the mouth and basically collect some skin cells from inside of the mouth to use for genetic testing too. So there are multiple different ways of collecting a sample for genetic testing. And luckily at this point, we're at a stage in medicine where they're all equally accurate. So there's no problem between any of them, which is good news.
Oh, very good answer. I have one quick follow-up. You mentioned skin. Would that qualify or classify as a biopsy?
Yeah, so it's called a skin biopsy. Yes, it's a small amount of skin is usually taken off of one of the arms, either the forearm or the upper arm. And it's called a skin punch biopsy. So a small amount of skin is sort of almost like punched out of the arm. It's not the most comfortable procedure, but there's some topical anesthesia that goes on. So it's not going to be something that's going to be super painful, and they're going to take just a really, really, really tiny bit. And from there, they're actually going to send that little bit of your skin to a lab that's going to grow your skin in a petri dish, basically. So they're going to grow a whole layer. That's why they only need a tiny little bit, because they're going to create more. And then from there, the larger amount of skin that's produced in that dish, that's what goes off for genetic testing. So they're not going to take off everything that they need. They're just going to take a tiny little bit, just enough for them to get enough of the sample growing so that they can do the testing for you. But yeah, technically it is a biopsy. Yeah.
And would that be seen by a pathologist at the same time, or only a pathologist?
Yeah, it's not going to be seen by a pathologist. That's an excellent question, because the biopsy is not to see if there's anything wrong with the skin. The biopsy is just there to grow a kind of sample that's needed to do the genetic test. So they're not going to do this biopsy to see if your skin has cancer. This is just the kind of biopsy that's done just to get a different kind of sample to do a specific kind of test. If, for example, you have they call it a lesion, but, a mark on your skin that doesn't look quite right, and your physician is worried that you might have some kind of skin cancer, that kind of biopsy where they take a little bit of what they think doesn't look quite right, that would definitely be sent to a pathologist, and they're going to take a really close look at that to see, is this normal looking skin, or is there anything growing here that we don't think really should be growing here? And then we need to take some kind of further action. So that's a different kinds of biopsy. Biopsy just means taking a small part of your body out, but it doesn't have anything to do with what you're doing with it. It's just sort of a technical term for just taking a little piece of you.
And then the process, some people have concerns that once they've taken whatever they've taken, they worry about it being delivered as soon as possible, because there may be an expiry on or the timeline has to be as quickly as possible. How do you reassure a patient that, don't worry, everything is going to be processed efficiently?
Yeah, so I gotta say, speaking as a true passionate genetics nerd over here, DNA is one of the best kinds of molecules to work with. And that's because it's really stable. So it can last for years. It can be, made super hot or super cold. So in Canada, you know, we have the really hot, humid summers and then the real cold, brutal winters, and DNA is fine in all of that. So it's the same reason that we can do sort of genetic testing on these, you know, ancient mummies that we find from their teeth and things like that, because DNA is really stable. It actually takes quite a bit to destroy DNA. So, so you don't need to ever worry about your sample being corrupted by waiting too long to be sent into the lab or by sitting in the hot sun. None of that is going to have an impact on your DNA, which is really good news.
Okay, great. I'm sure that takes away a lot of the questioning for some patients. I'm going to go to question number 2. Thank you. That was very informative to start our session with. Should everyone diagnosed with breast cancer have a genetic test done?
That's an excellent question. So the question, who should consider genetic testing? It's really one that changes sort of year by year. So the answer that I give right now, it might not be the same answer that we are going to talk about next year. So just keep that with a grain of salt, that genetics is a relatively new field in medicine. So things change quite often. So that means each year we're going to have new guidelines that tell us really who we should be doing genetic testing for. And it also, in Rachel's opinion, gives evidence to suggest that, you know, maybe anyone who wants the information should really be able to have access to it, because it could be that maybe we don't meet those guidelines or the rules for who gets testing this year, but you might next year. And so I always just think if it's something that you're interested in, there's no harm in asking the question of, can I access this test? And if I can't access it through my provincial program, is there other ways that I might access my genetic information? But at this moment, really who we're looking for is people who they themselves have had a certain rare type of cancer, or people who have had many family members who are related by blood. So not through marriage, who are related to you by blood, who've had multiple rare kinds of cancers. And then also if anybody who has had genetic testing that was done previously, so done many years in the past, our testing has gotten better over time. So we might consider updating people's testing as we have more information we can use now. So here's just, I know it's very busy, but just to give us some references of what we're looking for. So when we're considering genetic testing in the clinic, we look for patients or people who have had family members who've had pancreatic cancer, ovarian cancer, or male breast cancer at any age. And that's because those are rarer types of cancers. And so there's more likely a chance that there was a genetic reason that those rare cancers happened in those people. We're also looking for people who've had breast cancer, colorectal cancer, that's colon cancer or rectal cancer, gastric, which is also called stomach cancer, or endometrial uterine cancer at the age of 50 or younger. And that's because people who are younger tend to have a higher chance of having one of these genetic risk factors for cancer. We look also for patients who have had prostate cancer at 55 or younger, or metastatic prostate cancer. So unfortunately, prostate cancer is a really common disease in men. And most times it's something that is very treatable, but for certain men, they get a metastatic cancer, which means cancer that has spread from the prostate. And that's actually pretty rare. So again, like we said, right, rare types of cancers have a higher chance of having one of these genetic risk factors be the explanation. So for anything rare, like metastatic prostate cancer, we would want to consider genetic testing. Triple negative is a kind of breast cancer that is a rarer type of breast cancer. And we would want to do or consider genetic testing for anyone who is diagnosed with that rarer type of cancer at 60, or younger. Anyone who's had 2 kinds of cancers, not including skin cancer. So unfortunately, skin cancer is really common. I'm a relatively young person and I've already had a couple little things burned off, you know, those summers in Toronto doing kayaking at the Harborfront Kayak School. All those burns I got, they're they're coming back. Karma is happening. So, so skin cancer is a very common type of cancer. So that's not really what we're considering when we say two types of cancers. But if somebody's had, a breast cancer and an ovarian cancer, or a stomach cancer and a breast cancer, those are situations that are pretty rare. And again, anything rare, we want to consider genetic testing. Also, anyone who's had colon cancer now would qualify for genetic testing, and anyone with any kind of other rare or younger cancer should consider genetic testing. Now, you might be saying, okay, well, myself, I haven't had cancer, but I'm really concerned because my family, I see it a lot in my family. Do I qualify for genetic testing? And the answer is yes, actually. So if two or more people in your family on the same side of the family, so either your mom's side or your dad's side, have had those same things, rarer types of cancers happening in younger people, or people who have had more than one type of cancer, then it's definitely a time to consider genetic testing, or at least talking to your healthcare provider about if there's benefit there for you for genetic testing.
Okay, that's a very good overview. I have a question. In terms of where we are at with the genetic testings, what, in your opinion, are yourself and others like you wanting to improve with the test? What is the next version, let's call it, of the testing that would be more, specific, more accurate, or more answers from the test?
Yeah. So Kathy, that's a wonderful question. And I feel as though there's sort of two ways we think about genetic testing in that context. One is technology. So how do we make the actual test better? And at this point, the testing is very good. So the chance that somebody, if they have one of these genetic risk factors for cancer, will get this test and it's going to find the answer is pretty high. As time goes on, our understanding of the link between genetics and cancer development increases. So we're going to discover new genes that are linked to cancer risk, and we're going to understand the genes that we currently know about better and better over time. So the test itself will continue to get better. It was only about 10 years ago that we were looking at only 2 genes linked to breast cancer, and now we have, over 100 that we know of. So testing has come a very long way in a very short amount of time, but we know we've got more to go. The thing that I actually would more associate with making things better is getting more people access to genetic testing. And that's because, of the millions of people who have one of these genetic risk factors for cancer development, about 90% of them don't know they have it. So that means that we're actually not doing enough testing to find the people that have these genetic risk factors. And we want to do that testing because there's actions we can take for the people we know have a higher chance of developing cancers. So I think that the testing itself has come a very long way. We still have more to go. And over time, it's going to just keep getting better and better. But at this point, we have very good testing. It's just getting people access to that testing. I think that's the main barrier at the moment. And if we can help bolster people's ability to get genetic testing done, I think we're going to be able to decrease the number of people that don't know they have these risk factors, and therefore increase everybody's ability to take better care of themselves and their families.
Okay, great. So now I'm going to turn it over to Jen. I'm sure she has some questions that came in during our first opening session here.
There have been a few questions coming in. So actually this one ties in nicely with sort of what you were showing in the last slide, Rachel, and gives a bit of a concrete example. So Janice asks, she says, my parents were both cancer-free, and yet 4 out of her 5 siblings, including herself, developed cancer. So would genetic testing be valuable for her daughter or for grandchildren or nieces and nephews? So in that specific family situation with that many sort of siblings with cancer, what does that look like for the next generations to come?
Yeah, that's an excellent question. So unfortunately, cancer is a very common disease. So about 1 in every 2 men and 1 in every 3 women are going to get cancer in their lifetime. So it's a very common disease, and most times it's not caused by problems in our genes. Most times it's caused by the damage that builds up in our bodies through the environmental exposures we have. I don't know about any of you, but I have to breathe. So even on those, ozone days or pollution days, and it's all smoggy, and I can sort of taste the emissions from the cars. I live in downtown Toronto, so that doesn't help. Even on those days, I still have to go walk my dog, and I'm still getting exposed to those toxins. I also can't prevent exposing myself to toxins as I eat and drink, and I need to continue living. And every day my body gets older, as much as I try to prevent it. If anyone has any tips, I'm open. But as I age, also, my body gets damaged. So that's normal, right? Those are normal things. We get damaged from our environment, from our lifestyle, and from the normal aging process. And for most people who develop cancer, it's actually a combination of those things, the environment, our lifestyle, and the aging process, that explains their cancers. So I'd say for most people, genetics is not the explanation for what's happening in their family. However, there's only one way to know, right? So we can't, there's no test that can be done to say, yep, it was on June 14th that you went on the bike ride and you breathed those emissions, and that's what caused your lung cancer. We don't have a test like that, but we do have a test to say, actually, for you and your siblings, there was a genetic risk factor. And it just so happened that it came from your father. And because he doesn't have as much breast tissue as a woman does, he did not experience breast cancer. But you and your siblings do have the breast tissue, and you did experience the breast cancer. So the only way to know if there's a genetic risk factor is to do a genetic test. I don't know in particular what cancers are happening in your family. So it sounds like there is quite a bit of cancer, but again, we expect as our bodies age that cancer becomes more and more likely. So if there were any rare cancers or young cancers, those are also reasons to consider genetic testing. But again, if you're just worried about what could be passed on to your children and your grandchildren, I would probably start with you yourself, because if nothing is found in you, you can't pass on something that isn't in you. So genes don't skip a generation. They go directly from parents to children to grandchildren. So if your genetic test doesn't find anything, that means there was nothing in you that could be passed on to a child. So if it's something you really want to know and it's information that you think would be helpful for your family, the only real way to know that is to get a genetic test. I hope that information was helpful.
I think that answers some of the other questions as well. So there's some very specific sort of like, if this, then that, and then what, right? But it sounds like, really to your point, having that genetic test is the only way to actually confirm whether or not there's genetic mutations. So questions around that then, if someone wanted to proceed with getting genetic testing based on however many people in their family who've had types of cancers, is this covered? So this specific question is around, would it be covered by OHIP? But that's sort of our Ontario healthcare provider here. But so is genetic testing broadly covered by the various public healthcare systems across the country? And so how do we sort of navigate that? And another question tying into then, like, what if it isn't? How could I get another test? So it's a bit of I've gathered a couple questions for you, but hopefully you can sort of help navigate folks through what that would be like.
So the answer is yes. Our provinces do a great job of doing testing for people who need it. So we have certain rules that we have. So people that meet these guidelines, they can get a genetic test, and it's covered by provincial healthcare. As we can imagine, it's in everybody's best interest to try to find people with a genetic risk factor for cancer before they've had cancer, and try to prevent them from getting cancer, because cancer not only affects you and your family, but it's also a very expensive disease for our healthcare system. So it definitely protects our healthcare dollars to make sure that we're finding people, hopefully before they've had cancer. That being said, the rules for genetic testing for who has access to the genetic test are pretty strict. So you may not qualify for your provincial genetic testing, in which case there are two other options for you. So they're both private pay companies. I work for one full disclosure, I work for one of the companies. And one of the reasons I work for this company is because I want to help my country have access to genetic testing. So this is a way that people who don't qualify for the provincial testing can still have access to high quality genetic information to be able to get their genetic information. So there's two companies that offer private pay. One is called Color. They look at 29 genes that are linked to cancer risk. It costs $249 US at this moment in 2022. Things change over time, but at this moment in time, this is the information about it. They have complimentary genetic counselors. So they have people like me when you get your results who you can talk to. And then they offer family testing for $50. So if anything is found in your family, in you, you're found to have one of these genetic risk factors for cancer, then your blood relatives can have access to the same genetic test for $50. So it's a discount if something is found. And then results are ready in a few weeks. So I'm not sure if anybody here is familiar with the wait times to see our provincial genetic services, but they tend to be very long. When I was in practice, the wait time to see me was about 2.5 years. So that can be quite a barrier for people. And it really doesn't help us if we're trying to prevent cancers. We want to do that in a time frame that's a little faster than years. So again, another reason why a private option can sometimes be good for families. I work for the other company called Invitae. We offer a panel. It's got 84 genes on it. It costs, again, $250 US. Again, genetic counselors like myself on the results side to be able to walk you through what those results mean for you and your family. And if you're found to have any genetic risk factor for cancer, then all of your blood relatives will get free testing through our program. And again, results are ready in a few weeks. So just to summarize, yes, our provinces have great testing. Actually, some provinces will send out for the testing. They don't always do it themselves, but some provinces will cover your testing if you meet their guidelines, their rules for who gets the test done. I think that the numbers are telling us that the system is not really capturing all the people that we need to be, because like we said earlier, 90% of people that have these genetic risk factors for cancer don't know that they have them. So we're not really testing enough people. And that's just because our system doesn't have enough genetic specialists. So there is a private option where you can go to get this information if you want it. One caveat to the private option is there are these tests called direct-to-consumer testing. They're oftentimes combined with things like ethnicity testing or ancestry testing. You get to find out where your ancestors came from, and it can be quite fun. But the funness actually means that it's not really the best medical grade test. So I would not recommend doing genetic testing for any kind of medical information from a company that is providing genetics in more of a fun recreational way. Those results aren't going to be as reliable or as comprehensive as you get from a medical grade genetic test, like the other two that I talked about. Was that information really helpful?
Yeah, because we did have a couple questions about like the ancestry.ca. And so you've now answered that in terms of what is the best option if you were to pay out of pocket for tests. So you've already answered some of those questions. So maybe Kathy will go back to some of the ones that were submitted in advance.
Yeah, before I do that, I'd like to continue on this. So the ancestry tests, when they do these fun for knowledge tests, do they actually look for genetic features, and what do they do with that information?
Yeah, that's an excellent question, Kathy. So they do look for markers that can indicate a higher risk for developing cancer. They're just looking at so few that it can give us false sense of reassurance. So I had, for example, I had a young woman come to see me, and she had developed breast cancer at 32. And she said, "How is this possible? I did a 23andMe test and I had the health information added in there, and it told me I didn't have any genetic risk for breast cancer. So how am I so young with breast cancer? And I said, oh gosh, this is really heartbreaking, because her mom had had breast cancer in her 20s. Her grandmother had had breast cancer in her 20s. And really, this young woman should have had screening or had some attention paid to her much earlier than when she developed this cancer. And maybe it could have even been prevented with certain actions. And none of that was taken because she had done this test and thought that she was genetically cleared, nothing there. So the reality is that these tests, they look at small snapshots of our genes. They don't look at the whole gene. So I sort of say, it's like if you're in a helicopter and you're looking down at a neighborhood and you see, you know, a couple houses have some pools. And then from there you say, wow, this neighborhood, everybody has a pool. But in reality, if you went door to door, you might find that, oh, maybe it's only like that small block that had pools, and it's not really the whole thing. And maybe the whole neighborhood's a little run down, and you just couldn't see that from that high up. So it's sort of like that. The medical grade testing, it's sort of going to go like door by door to check out the neighborhood. What's it look like? Is there anything that's sort of run down? Are we getting any hints of anything wrong here? Whereas the direct to consumer testing, it's going to take a much higher perspective and say, based on these two houses that I can see, I'm going to make a call about everything. So you can see why that's not quite as accurate, and it's not really going very in depth. It can also provide very, information that's not very helpful for people. So you can get a false sense of security, and your test might say, yeah, nothing was found. And you might think, oh, good. Okay. I don't have any genetic risk factor for cancers. And that might not be the case. So that's why these tests are really fun. So if you want, they're very good at determining, where your ancestors originally came from. If you have any relatives you didn't know about, they can be a lot of fun, but I would say just keep it like that. Keep it fun. But if you want information that could be medically important for you and for your family, then you should go with a medical grade test. So that's something that's not done for fun. It's done to help you be healthy and safe.
And is it all ancestry services, or just the ones that are marked health ancestry service? Like, are they all looking for trouble, or are they only looking for trouble if you ask for it, or are they only looking for who your family ancestors are? Just
so
quickly.
a lot of these companies, they offer multiple different packages. So you can ask, where do my ancestors come from? And I want to know any health information, or where do my ancestors come from? And I want to know if I have any, digestive sensitivities or something. But these that I have here are the only two medical grade tests that people can access for themselves in Canada. So, so these are two tests that a patient, a community member, my next door neighbor can go online and order for themselves. These are the only two medical grade ones that you can do that. Anything else is going to be probably something for fun. And again, things change. So this might not be the same next year, but at this moment in time, these are the two tests that I would recommend.
Okay,
and
good.
If you get a positive, so if you do have, there is a genetic mutation detected here, a genetic counselor walks you through it, what that means. What someone's asking, what do you do with that then? Do you take that to your doctor? Like what's the entry point to get into the health system with that information? And what do you do? So who do you go to see in the health system with that info?
Yeah, that's a wonderful, wonderful, wonderful question, because this information is not helpful unless you have a healthcare provider help you put into action the plan that you talked about. So you get your results, you speak with a genetic counselor, and they say, hey, you actually need to consider getting a mammogram once a year and a breast MRI, or we need to consider breast ultrasound also for your screening, or you actually need to talk to a surgeon, because actually a prophylactic mastectomy, so removal of the breast tissue, is something that is an option for you to make sure we're keeping you safe from breast cancer. So you might have options that your genetic counselor can't really do anything with. So the question of, okay, what's next is very important. So your genetic counselor will give you a whole written summary of what you talked about and the next steps that they're going to recommend. And then from there, you can either make an appointment with your family doctor, an oncologist, a breast surgeon directly. But usually your family doctor is going to be the person who you're definitely going to want to share a copy of that consult note. So it's just a letter that the genetic counselor writes out, but it's called a consult note. You're going to want to share a copy of that with your family doctor. If you don't have a family doctor, now is the time to get one, because any of those next steps, it means that you're going to need some extra attention in your health plan that other people aren't going to need. And your family doctor is really your point person. They're the one who's going to send you to all the different, specialists that you might need to see, get you linked up with all the screening you might need to get done. And they're going to be the ones that can keep track of things over time. So if you don't have a family doctor, that's a good time to look around and get one. And then making an appointment with your family doctor, sharing a copy of those results, and then your family doctor can then set you up with all the next steps for any kind of screening or any kind of specialty appointments you might need. So that would be the next step. Yeah, but you're never going to be denied that family doctor appointment based on if you had a private test. So that's not a problem. You just need to call your family doctor's office, say, I had a genetic test done, it was positive, I saw a genetic counselor, and I need to follow up with you based on these results. And you will not be turned away for that.
Great. Jen, can I move on to submitted questions now?
Absolutely.
Okay. So have a submitted question that reads, I had breast cancer and my report from Invitae shows BRCA2, exon 11, among others, and uncertain significance in bold. What does uncertain significance mean? And if a patient wants to follow up with a genetic counselor about this, how should they proceed? And I think it goes to what you were speaking to, correct?
Yeah, so there are three, you're right. There are three kinds of results that we can get back from genetic testing. And it all stems from, we're going to just do a little basics here that basically our body are made out of, many different parts that work together. And our DNA is the part of us that directs us how we grow, how we, what color our eyes are, how our voices sound. So our genes are the part of our DNA that give the instructions on how we are. And it's totally normal to have differences in our genes. It's completely normal. That's why we all look a little different, it sound a little different. Even aspects of our personality are controlled by our genes. So it's normal to have differences in our genes. And some of our genes are in our bodies to protect us from cancer. So they're like our little bodyguard. We're born with a set of these genes, and they're there as our little cancer protectors. And I have it here as our little bodyguard gene. And they recognize cells that are getting damaged from life. Life happens and it damages us. And they recognize these cells and they get rid of them, or they repair the cells. Now, we get these genes, as I said, from our mom and dad. We pass them on to our children, and we share them with our siblings. They don't change over our lifetime. They usually don't change in our lifetime. And they're not contagious. So they're not something that we can, get too close to somebody and it can be passed like that, like germs. They're in us and they're part of us, and they don't change over time. And basically genetic testing is trying to see, is there any changes in your little cancer protecting genes that would make those little protectors then not work properly? And these are those hereditary risk factors. So these are those genetic risk factors for cancer that can be passed through a family. And the question is, okay, what is a variant of uncertain significance? So previously we saw we have those changes that can happen in our genes that cause problems. So that's a positive result. That means we found a problem in one of those genes, and you were born with less protection from cancer compared to other people. Now, the thing is, we have millions of differences in our genes. That's what makes us beautiful and unique. And because genetics is a relatively new field in medicine, we're oftentimes finding differences between people's genes that we just don't exactly know what they mean at this moment. And we call those differences that we don't know exactly what they mean variants of uncertain significance. So if the genetic difference is found and it's just later on discovered that that difference was just part of you being unique, beautiful, different than other people, it's then considered benign. So that's a non-harmful change, just part of one of the many ways that you are unique as an individual. And we know that that most of these variants of uncertain significance are benign in nature. So over time, as our understanding of genetics develops and our implementation of genetics in healthcare increases, we're going to learn more and more that these uncertain results are usually benign. They're also a very common finding. So about 1 in every 3 genetics results is a variant of uncertain significance. So you're by no means alone with this result, okay? It's very common to get this type of result, and they're almost always benign. So they're almost always just you being unique and beautiful. They're just one of the ways we found that you are unique. We just don't know exactly what they mean right now. So over time, as our information and our knowledge increases, they're usually resolved. It can take months and it sometimes takes years. So it's nothing that I would get hung up on. We don't make any changes to anyone's medical care based on an uncertain result. So you certainly wouldn't want to take any medication or make any changes to your healthcare if someone said, hey, there's this sort of unclear thing, right? We don't want to make any changes to your healthcare based on something that's unclear. That's just not good medicine. So we're going to wait and figure it out over time. But in the meantime, we're going to make decisions based on your family history and your personal history. So we're going to use the information about your body as it is now and the history of your family to say, okay, based on those things, are there any changes we need to make to your health plan to treat you differently than other people or to keep you safe moving forward in a different way? So variants of uncertain significance are very common. They're nothing to be concerned about. They're usually just one of the many ways that you are unique as a person. We just can't be sure of that at the moment. Over time, they're usually clarified, but it can take a long time. So in the meantime, we kind of ignore those results. And instead, we're going to use the information about your body and your family to come up with a tailored plan for what's right for you.
Okay, that's great. Wow. I have a little question concerning other pickups during these genetic testings other than cancer. Do you pick up any other features? Are these features in cancer also indicators for other diseases? Is there something there that you can explain around this?
Yeah, so that's a really interesting question. So we have genetic tests that we can use in many different disciplines. So, for example, before I worked in the hematology and oncology fields, I was working in newborn health, and I was doing genetic tests on newborns that weren't quite processing food correctly. They weren't metabolizing food correctly, and that could have caused them some problems. But luckily, newborn screening catches those babies early. So we can use genetic testing in many different fields to help people live healthy lives or provide explanations for what's going on in their bodies. We use genetic testing in cardiovascular health. So people who have had, recurrent and early heart attacks, for example, or people who have an abnormal heart rhythm, meaning their heart doesn't beat at the right frequencies. We also use genetic testing for children that aren't developing properly or having some abnormal symptoms as they're growing. So there are many different fields that we can use genetic testing. But if the question is in the cancer field, if you do one of these cancer tests, is there anything else you're going to pick up? The answer could be yes. So oftentimes when you get a genetic test, they're looking at genes that are not just linked to one type of cancer. So many of these genes are in our bodies to protect us from more than just one thing. So the BRCA1 or BRCA1 and BRCA2 genes, they're genes that are in our bodies to protect us from breast cancer, ovarian cancer, pancreatic cancer, and melanoma. So those 2 genes are there to protect you from more than one type of cancer. So if you had a genetic test done and it found a a change in one of those genes that made it not work properly, not protect you properly, it would actually mean that you had a higher risk for all of those cancers, not just one. So when you do a genetic test, you might find information that you're not expecting. You might find that you're at an increased risk for a type of cancer that's never been seen in your family before. But again, information is not harmful. We're going to use that information to try to keep you and the rest of your family safe. So if the question is, am I at risk for any type of cancer? Which ones? And what's my risk? Then you kind of want to know everything that's there. So surprises may feel shocking, but are really just very helpful for answering those questions of what do I need to know about? What are the risks associated with these genes? And what actions can I take to try to keep myself safe from those types of cancers? And how does it, of course, impact my family? There are some genes that are linked to more than just cancer. So there are certain genes that you might also have a higher risk of having, abnormal patches of skin or having eye disease or kidney dysfunction. So you might sometimes find results through genetic testing that you're not expecting. That's why talking with a genetic counselor after you get your results is really important, because you need someone who understands to be able to walk you through what does it mean for you and your body? What are the next steps to keep you safe and healthy? And how can that information help your family members? So I would just say, talking to a genetic specialist is really important. And certainly, me and all of my colleagues, we want to make sure that you get the best information, because sometimes we can get results that we're not expecting from genetic testing and we can't get surprises. Yeah.
Thank you. I'm going to move on to the next question. It's a little bit different from what we're discussing, and it's the implications to insurance. If someone has genetic testing done and the test is positive for certain mutations, for example, they're asking, will my premiums go up? Will I still be able to get life insurance, etc.?
That's a very important question. What a great question. And we need to make sure that everybody feels secure in getting the information they need to feel safe, and that they are safe getting that information. So we're very lucky in Canada. We have a law that was passed a few years ago and then upheld again 2 years ago. It's called the Genetic Non-Discrimination Act. So there are laws in place that protect you from genetic discrimination. This is a Canadian legislation that prohibits insurers and employers from discriminating based on an individual's genetic information. In fact, it makes it a criminal act, punishable by up to a $1 million fine or possible imprisonment for 5 years. So this protection extends to disability and life insurance. And in fact, actually, the Canadian law goes further than protections we see in some other countries. It states that no one is permitted to require someone to take a genetic test or require someone to disclose the results of a prior genetic test. And that goes for anyone, so not just for insurers. So school systems, landlords, condominium boards, literally anyone. No one can ask you for that. The only people that can request this information are healthcare providers and researchers. It even goes further with a final prohibition that's not very common in many other genetic discrimination laws. It prohibits anyone from collecting, using, or disclosing someone's genetic information without their written consent. And that's important because in an age where so much personal information is stored online, this prohibition becomes very important. So a third party, if they come into possession of your genetic information, they're not able to use your information in any way without your written consent. And again, that's really important as we think about, what's stored online and what information can be shared. So this law doesn't just protect you, it protects you from, discrimination directly. It also protects you indirectly. So any third party also cannot use your genetic information. So we're very lucky in Canada to have these very strong protections for our genetic information. And then of course, any medical information is also covered by the Personal Information Protection and Electronic Documentation Act, which is just a very long way of saying all of your health records are kept very private. So there's even further protection for your genetic information. So I'm very happy to say that in Canada, we have great protection for our genetic health information.
Good. That's reassuring. I'm sure to many people who've had that in the back of mind, or if they didn't, now they know.
Yeah.
Jen, I'm going to send you to the live questions. Do you have any?
We do. So what are some of the most common genetic mutations that are related to breast cancer? And then what's the implication for someone who is identified as having those genetic mutations?
Yeah, that's a wonderful question. So the most common genetic predisposition for breast cancer comes from two genes, the BRCA1 or BRCA1 or the BRCA2 BRCA2 genes. So these are genes that were discovered, many years ago. They were the first to be discovered to have a link to cancer, and it stands for BRCA1, which stands for breast, BR, cancer, CA, gene 1, and BRCA2, breast cancer, gene 2. So I'll give you two guesses what kind of cancer they discovered was linked with these two genes. So they discovered that these genes are linked to breast cancer. And this was a really, that is the way that cancer genetic testing started, was these two genes. And they continue to be very important in our healthcare because those are the two genes that are most commonly found to have problems in them in people with younger breast cancers or these rarer types of breast cancers. Now, the other part of that question of, okay, you found out you have a BRCA1 mutation, you have a problem in your BRCA1 gene, it's not protecting you properly from breast cancer, ovarian cancer, pancreatic cancer. What do you do? That's a wonderful question, and we're going to be able to talk about that. So what does that mean? So you're found to have what's called hereditary cancer. So you have a genetic risk factor that puts you at a higher risk for certain cancers, or you yourself have had one of these types of cancers and you have a genetic explanation for why it happened to you. It could impact your therapeutic decision-making. So there are certain medications that have been made and target certain cancers that are developed by these problems in these genes. So you might have a change of medication. You might be eligible for different types of surgeries. So for example, if you've had breast cancer and you have a BRCA1 mutation, you have a problem in your BRCA1 gene, you might be at a higher chance of having a second breast cancer. So your breast surgeon might talk to you. Actually, instead of doing a lumpectomy, removing a small part of the breast that just has the one little bit of cancer cells, the clump of a problem, we might be talking about removing all of the breast tissue to make sure this never happens to you again. Of course, no one can do anything to your body without you being in control of those decisions. So your surgeons are just going to tell you all the options that you might have available to you. And people with these genetic risk factors might have different surgical options than other people. And then there are clinical trials that you might be eligible for. So there might be newer medications that could potentially work very well for you that you might have access to because of this genetic testing, that then they're find, oh, these are the medications that are being trialed and might be, very good for you. And then after treatment, or if you've never had breast cancer or any other type of cancer, you could have different kinds of screening or prevention options for you. So we might be talking about more frequent screening or totally different types of screening. So more frequent screening being, maybe you get more frequent mammograms than other women, and different types of screening. Actually, maybe you need a breast MRI instead of just a mammogram, because that's a more sensitive way to look at your breast tissue. We also might be talking about chemoprevention. So there are certain medications that you can take that would reduce your chance of ever getting a cancer, or surgical implications. So again, removing the breast tissue before there's a cancer means that it's highly unlikely you'd ever experience a breast cancer. And for some young people, that's a very reasonable option for them that they would like to take advantage of, and or anyone at any age. But before there's a cancer, that might be something that speaks to people as a good option for them. It also means that your family has access to potentially life-saving screening and testing as well. So if you're found to have a genetic risk factor for cancer, each of your children has a 50% chance of having that same risk factor. So they would also be eligible for genetic testing, and then the screening, all of the ways that we would try to keep them safe as well. And then for some people, genetic testing gives answers. So it just provides you with the information you need to know where this came from. You lead a healthy lifestyle, you're young, you live in the countryside, you don't have to breathe all the terrible air that I do. And you're thinking, how did this breast cancer happen to me at 21? What did I do wrong? What did I do to myself? Genetic testing can maybe sometimes give answers to people and say, this was not anything that was preventable. This was something that was sort of something you were born with, a higher chance of having, and it can just give you an answer. For everybody, there's only so much we can do to try to prevent ourselves from getting cancer. I still have to breathe the air. I'm still getting older every day, as much as I try not to. There's only so much we can do, but for certain people, the explanation actually does lie in their genes, and that can provide some clarity as to their situation. So those are the reasons to consider genetic testing, what we would do with those results afterwards.
That's great. A good overview. I'm going to go to my next question. I have 6 granddaughters who all have a family history of breast cancer. So let's follow this. With 2 grandmothers and great-grandmothers who have had breast cancer, could any of these cancers have been inherited, and would genetic testing be helpful for them? And then she asks, I was told that ER positive cancers, which is what this woman has, are not inherited. So it's a big 2-parter. Take it away.
So, thanks, Kathy. So why don't I start first with the ER positive? So there is no one type of breast cancer that is not at risk for having a genetic reason for its existence. ER, PR negative, so what we call triple negative breast cancer, is more likely to be caused by a genetic risk factor. But even if you had a positive breast cancer, that doesn't mean you don't have a genetic risk factor. That just means it's less likely. Okay. But if a 21-year-old comes to me with breast cancer that's ER/PR positive, I'm still very suspicious, because that young person, their body hasn't been on Earth long enough to have developed the damage that I would think would cause a breast cancer. So likely there's another explanation, which is probably in their genetics. So the type of breast cancer doesn't mean 100% there's not a genetic risk factor there. In terms of your family history, that does sound like quite a lot of people in your family who have had cancer. So I would recommend considering a genetic test. We usually say that it's best to start with the person in the family who's had the youngest cancer or the rarest cancer. And that's because if there is a genetic risk factor that's passing through your family causing these cancers, you want to start with the person who's most likely to have that. So that's the person that's got the youngest or the rarest type of cancer. And that's the person that you're most likely going to get a genetic explanation from. Because once you have that, then you know exactly what to look for in every other family member. So that's where I would probably start with your family. But again, if that person is not available, or you're just motivated to get the information about what you might have internally that could have been passed to your children and then your grandchildren, then of course, genetic testing is available to you. Both through the provincial system, if you qualify for that, and also through the private system, if you don't, and you still want those answers. I would say that again, I keep being struck by the statistic that, 90% of people who have these genetic risk factors just don't know. So I'm hesitant to tell anyone that they they should not consider genetic testing, with a grain of salt that I'm a genetics expert and I believe everyone should have access to their genetic health information. So take it with a grain of salt, but if it matters to you to get the information, there are ways for you to get it.
And again, repeat, what is young? What is the age that you would, consider? I mean, you have multiple family members here, and you said go to the youngest first. What is that age?
Yeah, so usually when we're thinking about a young cancer, it's usually anyone who's less than 50. It depends on the type of cancer, though. There's some types of cancers that do affect young people more than older people. So say leukemia, for example, can either happen in early childhood or tend to happen later in adulthood. So there are certain cancers where that doesn't hold true, but I'd say for anyone with breast cancer under the age of 45, anyone with colorectal cancer before the age of 50, those are real things that I would consider to be younger cancers, and definitely a reason to at least consider genetic testing. Good.
I'm going to go to Jen. Jen, what other live questions would you like to ask?
So we have a question around someone who has tested positive for the BRCA1 gene and wondering at what age can children have genetic testing done?
That is a wonderful question. So that's a really good question. Okay, so we don't expect for children who have a problem with their BRCA1 gene, we don't expect them to have any health conditions until adulthood. So the genetics community has made a call together that we say, if there is no risk for a child to have any medical problems, then we recommend not testing children until they're adults. And that's because not everybody wants this information. And we want to maintain your child's ability to make those medical calls for their adult selves when they're adults. So we want to maintain their autonomy, their ability to make their own medical decisions. So if there's no reason to test a child, then we actually won't. We will have the conversation when they turn 18 or whatever the age is at each, country or province. But when they're an adult, they're welcome to have the conversation. In fact, I've oftentimes talked to pediatric patients, so children, or adolescents or teenagers. It's okay to start the conversation early. And sometimes teenagers make very good arguments as to why they feel ready and willing to get that information. But in reality, they're still developing, their brains are still developing and growing. And we want to make sure that we allow them to have proper development intellectually before they make these very big calls about their future health. So we don't usually test pediatric patients for any kind of adult onset condition or any kind of adult risk factor. So we'll allow them to retain their autonomy. There can be special circumstances where that's not the case, but in general, that's what we try to do. I hope I hope I've been able to explain why we're like that. We're not trying to prevent your children from getting good medical care. Obviously, that's what we want for everybody. We're just trying to make sure that if they end up growing up and saying, actually, I don't want this. I don't want to know this. I want to live my life free from this information. And I will go for the screenings and I will be healthy and I will take care of myself. But for a personal reason, this is not feeling like information I want. We want them to retain that option. I hope I've been able to be helpful with that and help you know that we're not trying to not take care of your children. We're just trying to make sure we're doing it in the best way we think possible.
For sure. I think that definitely comes through. Yeah. Kathy, we'll go back to you.
Yeah. So let's ask the next question. I had genetic testing done 5 years ago. Should I get it done again since we have a better understanding of different mutations now?
That's an awesome question. And the answer is maybe. So it depends on what you had done at first. And that's a very, very good question. I've met with patients who had genetic testing done 5 years ago, and it just looked at the BRCA1 and the BRCA2 genes, and that's it. And I just thought, well, those were negative, meaning they didn't find any problems in those genes, but there's a lot going on in your family, and maybe, you yourself have had cancer. And I just think there could be a genetic explanation. And maybe now we're able to get that answer because we know of so many more genes that are linked to cancer. So I think it depends on what you had done originally. If you had any, if they didn't find any problems in your genes originally, and you had, only 2 to 5 genes that were looked at, I would say it's definitely time to have a conversation about updating that genetic testing. As you can see at the company that I work for, we're up to looking at 84 different genes that are linked to cancer. So we know a lot more than we used to. I think it's definitely worth having a conversation. I know that it's a little bit harder sometimes to have that covered by the provincial healthcare system, but they are updating testing too. So that could be a really good conversation to have with your healthcare provider. And I think you're really onto something there.
Great. Jen, let's take more questions from the audience.
Yeah, so one around, if both the mother and a father have tested positive for a BRCA mutation, is it then implied, like, is it guaranteed that their kids are going to have that BRCA mutation, or what are the next steps there? Or is that a possibility that maybe their kids won't have that?
Yeah, so that's a complicated question, and I'm going to go through it step by step. So if mom and dad both have a mutation in their BRCA1 gene, they both have risk factors for cancers. So they need to be, first things first, they need to have different care than other people. When they have a child, right, we don't pass down all of our genes to each of our children, or else they get a double dose, right? So we only pass down half. So mom passes down half of her genes, dad passes down half of his. And each time we have a baby, it changes, which the combination changes. That's why siblings don't all look exactly the same. So for each child, there would be a 1 in 4 chance, so 25% chance, that they would not inherit either mom or dad's BRCA1 mutation. So they wouldn't have any genetic risk factor for cancer. There would be a 2 in 4 chance, or 50% chance, that they would inherit either mom's or dad's genetic risk factor for cancer. So they would be like mom and dad. They would need some extra attention to make sure we're keeping them safe from cancer. In the last 25%, the last 1 in 4 chance would be the offspring would get both mom and dad's BRCA1 mutation. And that causes a much more severe condition called ataxia telangiectasia. And it causes some very severe childhood onset cancers, and it can cause a lot of medical problems. So that would be a situation that we would absolutely test a child. We would test probably even a pregnancy if we knew that mom and dad were both carriers, both had these genetic risk factors. So that would be one of those instances where we would absolutely test a child, because we would definitely need to take care of that child differently than other children. And that child would be at risk for many childhood cancers. So yes, so I know it's complicated.
That's a helpful breakdown.
There's a lot there.
And is that the same if it was, we use BRCA as an example, right? The BRCA1 gene. If you have a mother and a father who have the same mutation, like a different gene, are the same implications there essentially, like that sort of breakdown? And does that then sort of initiate this genetic testing for children at an earlier age, or does it vary by gene?
Yeah. Excellent question. And thank you for giving me a chance to clarify. It's different for different genes. So if mom and dad carry a problem in the same gene, there could be a risk for an offspring, but not necessarily. It depends on what gene we're talking about. So it's just that BRCA1 is one of the, and BRCA2, these are genes that can be linked to these childhood onset conditions. If mom and dad both have problems in the same gene, but there are lots of genes out there that mom and dad can have problems in the same gene, and it would not cause any problems for a child. And then, there's lots of times when mom and dad might have different genetic risk factors. So mom has a mutation in BRCA1, and then dad has a mutation in MLH1. So it's a colon cancer predisposition syndrome. And those two don't interact to make any risk for a pregnancy or a child. So it really is dependent on the gene and what's in mom and what's in dad. And that is why speaking with a genetic specialist about your unique situation is very important. And trust me, we want to walk you through it. We want to take the time to help you understand what this means for your health, for your partner's health, and for your offspring's health. We want to make sure that you have all the information you need to make the decisions that are right for you and your family. But it's, as you can tell, it's complicated and it's individualized, and each family is going to look different too. So having those conversations with a genetic specialist can be really helpful. Yeah, but thanks for giving me a chance to clarify, Jen, that it's not all genes that have a risk to the next generation for these childhood onset conditions.
That's really interesting considerations. Thanks for clarifying.
So I'd like to ask you regarding the BRCA1, BRCA2, commonly known as that it's predominantly more in certain populations. And that has some people thinking that, well, I'm not in that certain population, therefore that might not be something I need to worry about. So maybe it's a two-part question. Is one, why is it in certain population, and how does this gene come about so more, at risk for a certain population? And if you're not within that population, why should you be tested? Like, explain that whole information that people often get confused about.
Yeah, so that's a wonderful question. So the phenomenon you're talking about is called the founder effect. So it's basically when a certain population goes from a large size, or community, large size, to a very small size, and then they're sort of segregated. So they create families with each other and then build up from this very small population. That can cause certain genetic risk factors that are rare for everywhere else to become more common, because these people that it got bottlenecked might have had, a rare, what used to be a rare genetic thing, but then they're the ones building out the population from that point. So that thing that used to be rare is now much more common. That's called the founder effect. And that's what we see in the Ashkenazi Jewish population, for example. They have higher rates of three specific mutations in the BRCA1 and BRCA2 genes. So anyone who has that, has ancestors that you would consider Ashkenazi Jewish, definitely should consider genetic testing, because they just have a higher chance of having one of those three mutations. Now, the second part of that question is, okay, I'm not Ashkenazi Jewish, so then what do I care about genetic testing? Well, the answer to that is that people from that community have a higher chance of those specific mutations. That doesn't mean that everybody else has no chance of any mutations. It just means that everybody else might not have those specific mutations, but they still have a risk for everything else. So unfortunately, I wish I could say, hey, you're not of this descent. Great. This is information that's not relevant to you. Unfortunately, that's not the case. Anyone can carry one of these genetic risk factors. You don't have to be from a certain population. It's just that certain populations have a higher chance of having these risk factors. The other thing that we're learning more and more as these ancestry tests, these like really fun tests that are out there are putting out their data, is that people might think their ancestors are from a certain place, but oftentimes they're wrong. So yeah, we're finding that like a very large percentage of people actually don't know where their ancestors are from, which is why those ancestry tests are so fun, because you might find things that you're not expecting. But it also means that even if you think you're not from a population that might have a higher chance of one of these genetic risk factors, there could have been some kind of family secret, or, we're talking about passing information generation to generation. I'm not sure if it reminds anyone else of any other fun game when we were growing up, but it reminds me of broken telephone. There's a lot of misinformation that, even though the message you think is being passed down correctly, over time, it can change. And what you think might be truth might not be your family's truth. So over time, we're starting to actually rely less on people's self-disclosed ancestry, because it's actually pretty inaccurate, which is, again, why those ancestry tests are so fun, because you might find something that's new. But it also means that we need to take that piece of information with a grain of salt when we're considering your medical, your medical needs, that actually that information is usually not very reliable. So we don't really want to be just testing certain populations for these genetic risk factors, because really any of us could be at risk. And you might fall into a category that you're not expecting. So we want to make sure that that's not a reason to not do testing.
And I would imagine that as you say, the Jewish Ashkenazi population is not the only population that fits that group. There could be other populations that have the same, buildup of their population, where they come down and they kind of live and, reproduce amongst. So
you're right. There are many different populations that have experienced that founder effect. And then, again, I just go back to that, 90% of people that have these genetic risk factors don't know. So there's probably populations out there that we just don't know that there is a higher chance of finding these genetic risk factors, because they just haven't been identified yet. So you're absolutely right, Kathy, that there's a lot out there that we don't know yet. And there are many populations that can benefit from genetic testing. And actually that's all of our populations. Yeah.
Thank you. Jen, do you have more questions from the audience? I'm sure you do.
We do, yeah. There's one around. So can diets and lifestyle changes actually modify our epigenome and reduce breast cancer or other cancer risks? Is there anything we can do in terms of diet or lifestyle choices that can change that?
Yes. So there are multiple studies that show that there is an impact to certain things within your control. So unfortunately, none of these things are going to make you at 0% chance of getting cancer. But there are certain things that have been shown to reduce our chances. And there are things that I do, actually, because I found the research so compelling. So one of them is eliminating meat, or trying to eat as little meat as possible. The other is actually going the next step, which is trying to reduce the amount of dairy that we're eating. So for me, in my diet, I became a vegetarian a few years ago because, again, I wanted to reduce my chances of getting cancer. And then a few years ago, when the publications were coming out, I reduced. I'm not a vegan yet. I really like cheese, but I'm doing what I can. So I'm reducing the amount of dairy that I eat and switching to things like almond milk or coconut yogurt, things like that. So there are some dietary changes that we can make that have been shown to reduce our cancer risks. So reducing or eliminating meat, reducing the amount of dairy, or the Mediterranean diet are all things that have been shown to reduce cancer rates. Lifestyle wise, I know I'm not going to shock anyone here. Okay. I'm not going to blow anyone's mind. 30 minutes of exercise a day. Okay. Every study out there has shown 30 minutes of exercise a day reduces your cancer risks, your heart disease risks, Alzheimer's, dementias. There are numerous health benefits to 30 minutes of exercise a day. And I know I'm a busy person, but I can't even say that I can't do 30 minutes. I scroll through, my Instagram or whatever, and, I know that I can make 30 minutes in my day. So 30 minutes of movement, the sweatier you get in that 30 minutes, the better. But those are two ways that you can drastically reduce your chances of getting cancer, as well as take us here in Canada, we need to take a vitamin D supplement. So vitamin D is also shown to help protect against cancer, and we don't get enough vitamin D. It comes from sunshine. So in the winter, I don't know if anyone else misses the sun, but I certainly do. And I take a vitamin D supplement because that's also been shown to be helpful.
Great. Jen, should I ask the last question? I believe we're going to do one more question before we wrap it up.
Yeah, we do have, well, we're able to take, I've got one more that's coming here around genetic testing and whether or not it can tell whether the risk is coming from the maternal or the paternal side of the family. And if that can actually be demonstrated through a genetic test, so then you can sort of, identify, okay, I just need to inform this side of my family that we have this issue and forget about this and not panic the other side of the family. Is there a way to do that through the genetic testing?
Yeah, that's a great question, because obviously that's going to have an impact on your family. And the short answer is most times, no, we can't tell. We can just tell that there's something not right in one of your genes, and it's causing that gene that's supposed to protect you from cancer, it's causing it not to work properly. But we don't know if it came from your mom or from your dad. So that's why whenever I was doing genetic testing for my patients and we got a positive result, meaning we found a change in one of these cancer protecting genes that would make it not work properly, I said, okay, next people to get testing, of course, your children, your siblings, and your parents. Parents first, because they're going to dictate, well, parents are part of that first round of testing for your family, because they're going to dictate which aunts and uncles on which side of the family and which cousins we need to then do testing for. So that's a great question. And unfortunately, I'm really sorry, but most times we won't be able to tell which side of the family it came from.
Okay, so I'm going to ask the last question. Unfortunately, we've come to this time before we wrap it up. So can cancer treatments like chemo and radiation, and I would include actually hormonal therapy, because some people go through hormonal therapy for a very long time, change your genetics?
That's a very interesting question. So I'm going to try and explain it so that it's not confusing, because the answer is yes, but not in a way that would impact your family. So the same reason as when you go in and you get an X-ray, I don't know if anyone can relate to this, but I'm quite clumsy and I've managed to break my arm multiple times. And every time I go in, they drape you in a whole lead outfit so that you can get your arm X-rayed. And that's because they're trying to keep you safe from the radiation that is in the X-ray machine. They're trying to keep the rest of you safe. And the reason they're doing that is because those X-rays, that radiation, can damage your DNA and it can cause cancer. Now, that type of cancer is not one that can be passed on to your children, and it's not the type of DNA damage or gene damage that you get from a parent. That's from those environmental exposures. So similar, if you were to have radiation as part of your treatment plan, it could down the line cause a second cancer for you. That is one of the things that your oncologist and your radiologist is going to talk to you about. That is a possibility. It's a low likelihood, but it is a possibility. So can it damage your DNA? Yes, that's what might cause a second cancer many years down the road. Is it something that you can pass on to your children? No, it's not like that. It's something that's going to be just in that one part of your body that was exposed to the radiation. Again, also, it's part of you making the decision that you think is right for your body, is knowing the risks to each of those treatments. So chemotherapy, radiation, hormonal therapy, all of these, surgeries, they all come with benefits and risks, and only you're the one who can make the call of what feels right for you and your body. But none of those are going to change your DNA in a way that you can pass on to your children. And none of that is damage that would have come from a parent. So those are things that can happen and they can cause a second cancer, but it's not something that we would consider hereditary or something that can pass through a family. I hope that did that explanation clarify the difference there? Yeah.
Yeah. Okay. It just tells you that it'll damage your personal DNA, but it's nothing that is going to be relevant if you're gonna, be passing it on to another. It's your own personal DNA.
Yeah. And to put it into perspective too, when we talk about radiation for treatment of cancer, we need to also take into account that we're exposed to radiation all the time. So the sun, for example, is one of the biggest sources of radiation on our planet. That's why skin cancer is so common. In fact, most of us will have skin cancer in our lifetime, but we might never know it because our cells just sort of shed off as we live our life, and our body is really good at getting rid of our skin cells every once in a while. Actually, we're bombarded with radiation all the time. And when we're talking about, can it damage our DNA? The answer is yes. Our skin cells get damaged all the time. That's why skin cancer is so common. So I just want to put it into perspective. It's not a reason that people should not treat their cancer, but it's something that you could consider as part of if you're making those decisions for your body, but also something to know that it's not something that will affect your children or your siblings.
Very clear. Thank you so much. And like I said before, this is it. This was the last question to a very, very good episode of our, questions and education. And at this point, I'd like to thank everyone who submitted their excellent questions and for joining us. And Rachel, thank you so much for this great discussion, information, and thank you. It was a wonderful session. And I want to thank again our sponsors, Beatrice, Novartis, Merck, Pfizer, and Invitae, who made this session possible. And thank you, everyone. Have a great day.